Bonsoir à tous et à toutes et bienvenue à cette conférence du Crash. Je m'appelle Judith Soussan, je suis directrice d'études au Crash. Donc voilà, je fais partie de l'équipe du centre de réflexion de...
Hello, everyone. We are very happy to, good evening. We are very happy to welcome Priscille Sauvegrain, who is going to tell us about the differential care for perinatal periods. Priscille has been a clinician and midwife since 1998. She's also a lecturer in midwifery at the Sorbonne University, and she's also a sociologist, so she has two hats as a researcher and a midwife, and this is therefore some skills and a dual legitimacy that we think was the perfect combination for our evening and our lecture tonight. And so we're going to benefit from her assessment of maternity and practices of caregivers in Île-de-France and the research she conducted for her dissertation. Now, of course, her work has to do with situations that may be observed in the French public hospital setting, but though it may appear to be quite far away from where we work, there are indeed some similarities, and there are going to be some, and these similarities are going to resonate with what she's going to tell us tonight. And you're going to see these resonances and echoes because, of course, at MSF we are particularly interested in perinatal care. However, I'd like to say a few words about what we wanted to do and why and what motivated our invitation of Priscille. Well, of course, the most obvious reason is that her work has looked into discriminations, and it's true that within MSF there have been some discussions in the last years about the issues of discrimination and racism, and the need and the necessity to decolonize MSF. However, this also focuses on the imbalance of power and the issues of salary grids and status for our personnel, and also the balance of power between the sections and the HQs, and the balance of power between the global north and the global south, and the necessity to revisit this distribution of power. However, I'd say that our patients are not really represented in this controversy, though they are at the very heart of everything we do and our social mission. So we thought it was important to tackle the important issue of racial and ethnic discriminations from the point of view of patients. And this is, of course, what resonates more particularly with Priscille's work. Now, I stand corrected by Priscille, but I think that the starting point for you is the matter of differential care and not discriminations. And now the issue of differential care is something that affects caregivers everywhere, and we can see how it does resonate with our practice and our issues, and because we keep wondering how we can adapt our practices and the care and the management we have for our patients is to better take into account their specificities. So Priscille is asking a question about the categorization and how the categorization is, on which is it based, and how these categorizations can become a problem. Now, of course, let me add that doesn't mean that categorizations are the the only way we have to adapt our practices. We also need to question the legacy of medicine, and also the notion of race and the colonial legacy, because these issues are at the very heart of the reflection on discriminations. What is highly valuable about Priscille's work is the way she deals with discriminations. Discriminations are a difficult subject. You may fear that the words you use are inappropriate. You don't want to wound people, to hurt people. There's the matter of using the proper words, and also from which standpoint do you take the floor? From where do you speak whenever someone mentions discrimination? So this is a difficult, this is a tricky issue, also because of the situations are very complex. They are, of course, multifaceted, and due to several factors, so things are not just obvious. And we were quite in accordance with the way Priscille deals with these issues, and how cautious she is, and how very carefully the words she uses are chosen. So this is quite remarkable. I want to let me add that this lecture has been organized and prepared together with Caroline Izambert, who is with us tonight. She is a historian and a member of the scientific board of CRASH. She's worked on the health of migrant people in France, and she had presented the outcome of her thesis in the framework of a CRASH conference a few years ago. I'm going to give the floor to Priscille for some 40 to 45 minutes of communication, and then we'll have a Q&A. Now, thank you very much, Judith, for your introduction. Thank you very much to Caroline and yourself for your invitation, and having taken the time to prepare this lecture. I've tried to use slides and use words that are not too medical, but of course do interrupt me if things are not familiar to you. But I'm sure that you've heard about all these perinatal situations. Now, thank you very much for your kind words of introduction. Now, what I'm going to tell you tonight is based on works that were carried out some years ago, and I will qualify these results because things have changed, and I think it is important to share with you outcomes that are validated by other people who've worked on these issues, and who have confirmed what I'm going to tell you. So I'm going to give you a warning when these results that I'm going to relay to you are a bit outdated. Now, we are in a European context whereby there are some differences in the way women are dealt with and taken care of according to where they come from, and more particularly for sub-Saharan African women, more particularly for eclampsia and pre-eclampsia. These are high blood pressure situations that are very critical moments during pregnancy. And it has been observed as well that that there is a higher risk of mortality in sub-Saharan African women, and I'm referring you to the outcomes of our survey from INSERM France. The risk is multiplied by almost 3 for these women born in sub-Saharan Africa, Southeast Asia, or South America. If you review the data more particularly for these women from these three regions, you can see that these women are black, most of them. So this is why, and of course, the higher mortality rate isn't as high as the ones you may observe in your fields, in your settings. It's in the order of 80 to 100 deaths per year. However, some adequate tests have shown that there is a higher risk for these women, and this is confirmed by what you get in data in Sweden or in the UK or in Belgium. Now, these statistics date back from 2010. These statistics were first gathered at the time, and then the collection of data stopped, and then it has now resumed. Now, these women from sub-Saharan Africa suffer from a delayed management. And this is in my thesis. Not only that, not only is there a delayed management, but for 78% of foreigners versus 57% of French women, the care which is given is not the optimum one. So close to 80% of women who were not given the proper standard of care is something that should call our attention. Now, the anthropological medical surveys were issues first explored by Pierre Ayage, Chauvin, these researchers are well known. However, I must say that this is a difficult issue because it's like a blind spot. It is a given that in France, everybody can get access to care. And it's also an individual blind spot for researchers. It's very difficult to conduct interviews when you are a researcher, to ask people about their precarious situations that may be associated with their poor health. And there's also this silo mentality from one specialty to the next, from one discipline to the next. And this is why that, on the one hand, there are sociological works that are mentioned only by sociologists or academics, and on the other hand, medical data that are mentioned among the medical community. Now, there are a number of us who have tried to work in order to move ahead. I am particularly keen to use the notion of differential access to care developed by Didier Fassin, and not only that, is also shown that there can be either a lowering or a raising of the standard of care, and I think this is something we can focus on. Now, these are differential care managements that are not medically justified. It is thought that, for instance, it is not useful to screen all babies for sickle cell anemia because then it would be too costly. So we could have differential care for sickle cell anemia screening. Now, the first thing I'd like to share with you is based on my thesis entitled Trajectories of Care or Pathways, Care Pathways for African Women in the public hospitals, public maternities. And I tried to identify who are these women perceived as African by caregivers in France. And of course, this is my main focus, but we could mention other ethnic origins, but just for the sake of time, I wanted to focus on the on my data, and I'm going to share with you only the qualitative side of my thesis because the quantitative data may be a bit older. I used semi-directed interviews with 54 caregivers, firstly in my network, and then people referred me to other caregivers who might have an interest to be interviewed. I was at the time on duty in maternity in Paris, and I had also stories reported to me by caregivers. I also met someone who comes from Mauritania and who wanted to specialize in social sciences, and I conducted several hours of interviews with her, and really a real life story. And now, coming back to the categorization process, how is it working? Well, whenever I started the interview, I asked, my first question was, who is African in your view? And this startled people a little bit. They were puzzled. And then I told them to focus on sub-Saharan Africa. And out of 54 interviews, there was only one child care specialist who told me, well, it doesn't mean anything to me. I don't want to discriminate people on that basis. But you see, you don't refer to these women as black women, but you call them Africans. And this is why it's interesting to use this word, this expression, who is African in your view, and look at how it could influence the care pathways. Because then caregivers are very willing to share the anecdotes they have from dealing and caring for these women. And I didn't ask any questions on the culture of these women, but I was given a lot of examples of the African quote-unquote culture. For instance, the fact that because of their diet, there might be some link with diabetes, and so on and so forth. And whenever reviewing the transcriptions, the transcripts of our interviews to highlight the main points, in all these interviews, according to these caregivers, 15 years ago, when the interviews were conducted, there were no middle-class African women. These women, middle-class women, black women, were thought to come from the West Indies, from the French West Indies, and likewise for their partners. It was an interesting observation. Also, interestingly, some caregivers referred to subcategories, saying, well, it all depends whether they arrived fairly lately or and coming from Senegal, Congo, or Cameroon. And it's also something interesting, because all these categories are based on the knowledge these caregivers have of the different waves of migration. It is true that a lot of intellectuals from these countries arrived in France, but also there were also migrants who are workers, and you can see that the way these caregivers consider these different populations is quite specific. And then these categories are not stable. Very quickly during the interviews, they started referring to the Africans and giving the impression that these African women are quite specific and with fewer women being taken care of for non-mandatory, I was told. For instance, these women don't attend the pre-delivery classes, though in fact these women were not aware that these classes existed.
Elles sont très fortes.
And also they would say, oh, they have a very strong mental condition. They don't need to see a psychologist. It's not in their culture. But this is totally dated now. People don't say that anymore. So they don't go as easily for prenatal examination. This is still true. And on recent cohort studies, we showed that the prenatal diagnostic might not be offered to them as often as to other women, non-African women. Also, verbatim praising them for giving delivery in a smooth manner, easily. Midwives talk about that often. And yet, African women undergo 35% of C-sections versus a national average at 21%. And this figure remains pretty high over time. That's very interesting, because this representation is masking an epidemiological reality. African women get the highest number of C-sections, and yet among the prejudices of people, the caregivers believe that they give birth very easily. Now, Mr. Papernik, who is the father of in vitro fertilization, published an article on a cohort of black women in the U.S. showing that black women would give birth 1 week earlier than the other women. And he concludes his paper saying they need more support at the end of their pregnancy as opposed to the beginning. Well, I retraced the whole history of that protocol. Apparently, someone presented the results at a congress, and they decided, obstetricians decided that they have to follow up black women closer at the end of the pregnancy, but they decided they had to follow them up more closely at the beginning, much earlier. So they took a whole protocol of ethnic terms, and for years, women identified as African were convened 1 week earlier to the hospital because their pregnancy supposedly lasted not as long as other women, and the placenta was very mature. That's really a misuse of the term ethnic group based on a skin color. They extrapolate and believe black women have a shorter pregnancy, and then from one maternity to the next, they were not the same inclusion criteria, and women were never informed actually to come back. Why we wanted them to come back earlier, 1 week earlier, to the hospital, to the maternity. And they would say, oh, they're happy that we're taking more care of them. There was no opinion by any ethics committee. It's true that 15, 20 years ago, they wouldn't have ethics committee reviews, but there is no evaluation, zero evaluation. And, I was told, oh, it's because you didn't search correctly. But no, I was right. No evaluation on that. In 2010, the College of Obstetricians said it is not recommended to monitor earlier the pregnancy of sub-Saharan African women. And yet we've been doing that in France for 15 years. This is one of the very few results that raises the question of discrimination, differential treatment with a whole group on an institutional scale, because, you know, that's what happens in a hospital. And then on the individual plane, you know, I also scrutinized my own practices as a midwife, of course. You have to observe yourself and see why you would get into a routine and decide it's best to do like that, and so on. So you have direct discrimination when, for racial or ethnic reasons, a person is not treated as well as another one would be in a comparable situation. Well, it's, you know, sometimes caregivers think they are doing it in a better way, but it's a form of discrimination. I searched the results of TO2, trajectory and origins, and the health environment in France is one of the least discriminating environment. That's what users are saying. So in our qualitative surveys, we found the same thing. You know, migrant families feel they're welcome in most maternities in France. Now, as a sociologist and a midwife, a caregiver, I wanted to examine the purpose of those categories in a daily management. Like this is for post-partum care. And here we see the emergence of an idealized figure of the African mother, more autonomous, more self-reliant, having more maternal care to give to the child, and also their contribution to the knowledge on childcare has been minimized for a long time. It was not common in French childcare care to take on board and recognize the merits of African or North African culture of women. And then we saw more women from Africa coming to France in the 70s to join usually their husband. But this is really about a routine and daily practices. If during the postpartum period you believe a woman doesn't need you because she can deal with it alone, then you work much faster. You know, I've been an observer. Hello, madam. Yeah, great. How about breastfeeding? Is it okay? Yeah. And then they turn to, oh, she is the champion of breastfeeding. Great. And the same African woman might echo that, you know, it's easy for me to breastfeed. But sometimes she would say, you know, I don't know what I'm doing here. I have to call my mother in Africa to get advice because the caregivers around me don't know anything about breastfeeding. So there is a gap in, you know, the understanding here. But these African women, given their image, were given a little margin for care management. For, you know, in France, they insist on women breastfeeding exclusively, even though on a daily basis, mothers show that they alternate between the breast and the milk bottle, and they would breastfeed for a year and a half and 2 years while also giving the milk bottle. It's worth looking into that further. And then we looked at women who didn't want to have a C-section, and yet they had indications. We looked at a cohort of Chinese women versus African women, and the measurement of their hips. And actually, we let African go for a vaginal delivery much more than Chinese women who are supposed to have a more narrow pelvis. Now, for those interested in conceptual things, there is one notion that's interesting to think about. It's what we call the social loss or attributed social value in a cancer department. They showed that nurses were more or less affected by the death of their patients, and they would be more affected by the death of a woman who never smoked and has 3 children, and they would be less sad seeing a man who smoked all his life without children die. So you attribute a sort of social value to the other, to the patient. And that does have an impact on the quality of the care management and the support you get. The variables that determine the social value are age, gender, ethnic group, social class, and so on, family status, health status, and the social value of African women was heightened because of their great qualities as mothers. You have a whole feminist literature trying to deconstruct that because, it's what we call a naturalizing form of judgment. We don't have time to discuss it at length, so I leave it at that, but it's really interesting to look into that. And on a recent research project, we try to link that with a paper from American literature about the implicit bias of caregivers. Here we talk of social psychology and testing the cognitive reactions of the persons being tested, like a preference for black people rather than the white, heterosexuals versus homosexuals, women versus men. Those are psychometric tests. And there is a whole new investigation on the issue of implicit biases. We tested that for the world of a child care work, and a paper will soon be published about that. Now let's have a look at the second line of research. That was a post-PhD dissertation. And we thought, can't we explore this hypothesis of differential care, but in a slightly different way, around the management of high blood pressure in African women versus French women. Now, we had an ethics committee examine the protocol. We wanted 3 groups: women born in France, white, French parents, but the ethics committee didn't want us to add the adjective white, but you understand the contrast we wanted to have. And then, because we saw it in a population survey in northern Paris area, in the suburbs, a risk factor higher maybe for women born in France of 2 sub-Saharan parents. The ethics committee barred that. So we had to compare a group of women born in sub-Saharan Africa and some born in France of French grandparents. And we wanted to study the whole care pathway, particularly differential care pathway, to see if we could explain this difference we find in the literature around different rates of prevalence. High blood pressure is a good choice because the diagnosis is easy. You take the blood pressure and then the urinary test strip to test for preeclampsia, and the management of that is very standardized. We decided to dive deeper into it. Now, this is a survey done on severe maternal morbidity. Sorry for the epidemiologists. You might find that a bit short, but we do show, all things being equal, that women born in sub-Saharan Africa are really more at risk compared with women born in North Africa, which perinatal results are closer to those of the group of women born in France. And this applies to a whole set of pathologies: severe high blood pressure, many hypotheses in American literature, genetic or social or a bit of both, for high blood pressure. But if we look at severe obstetrical hemorrhage with a ratio adjusted at 2 for Africans. They are twice more at risk of having a severe hemorrhage, even though it doesn't depend much on individual factors. So this again, it's a matter of quality of care, and it indicates that they had a lesser quality of care given to them. Now, more interviews, observation phase, but I was not participating. It's not where I was working, but I carried out interviews with women, looking at the way their health was managed. We did a pilot study. It's the only time I did that. I did 7 interviews. I was not able to analyze them. Women had severe high blood pressure accidents, and they didn't remember what care pathway they had got through because of that severe accident. So we kept only 33 of these women for interviews. And we really worked at the medical records, epidemiologists and sociologists working hand in hand. Analytical saturation was reached, and the outcomes show really the importance of differential care. When you find a high value, when you check blood pressure, it is recommended to explore the blood pressure for 30 minutes, the patient being lying. And in the African women's medical records, and there is a verbatim I'll be reading later, the caregivers would skip the DINAMAP step. The African woman comes, they take her blood pressure, and then they see that the blood pressure of that woman is down, and they don't check it again. She doesn't get the DINAMAP. And this woman said, I always had blood pressure, but if I wasn't running, it was around 150, but if I was quiet, it would go back to normal. And I asked, how do the caregiver take your blood pressure? They have adapted armbands. At the beginning, they told me to rest, and then they would control, but it was not better. And she goes on. Then they know that the blood pressure will not go down, so they check on her then every 5 minutes. And those who didn't have that, because they had precedents of high blood pressure, they were screened earlier, and still they say exactly the same thing for about their previous pregnancy. Also, the urinary test strip, if it's positive, you have to send it to the lab. And there again, it was done much more rarely. In the records, you find that the lady did 1, 2, maybe 3 urinary tests. You never find that in the records of French women. For those who have done it, it's really painful. It hurts. So having to do it twice, 3 times is really kind of painful. And then the measurement of proteins in urea, nephrologists and obstetricians don't always agree, but at several consecutive consultations, they were tested for that. 7 Africans versus 2 French. And the diagnosis is kind of gray. The woman arrives, rushed to the hospital. She's a bit hypertense. Then she's got a bit of protein in her urine, but you can't find it in the second test strip, so we let her go.
Now, it's also fair to say that some women didn't want to go to hospital more frequently, and they had them for instance, they had their blood pressure taken at the pharmacist, and the blood pressure was a bit high, but she decided not to go to the hospital, and she was told by the pharmacist that she had to go because really there was some edema. There was a swelling. But she went to 3 different pharmacies, and no one told her, don't come back to us, go to the hospital directly. So you see that there are some loopholes in the way these women are taken care of. On the other hand, and that's quite interesting, observed again in the implicit bias study that we did recently, whenever these women are in severe conditions, and in some cases these women may be who would have seen a deterioration of their condition in any case, but I have to say that whenever they are faced with severe complications, well, they get access to the same protocol as the others. However, we've been able to show that there's delayed diagnostic, more particularly for women without a personal history of high blood pressure. And by way of conclusion, what I like to say is that it's interesting to see how the thing we do in a routine way, a bit of systematically, without thinking, well, with these behavior that is a sort of routine behavior, and the way African women are dealt with at the first consultation, and then at follow-up, and all the more so because of the way hospital personnel are overworked. And you can see that whenever the woman is a lawyer or is a doctor or a doctor's wife, or if this is the first child or the third children, the third child, well, things are done differently. And so depending on who the woman is, irrespective of the ethnic or racial background, depending on the social category as well, well, you have a sort of procedure that you apply, and therefore it's a way to deal with patients in a way that is absolutely not putting the patient at the center and is not personalized at all. Now, there's another thing I'd like to say about the obstetrical violence and also the discrimination because of your ethnic or racial background or social background. These are reasons for being subject to violence during healthcare, and we need to do better. A lot of women in their blogs claim for better management in maternities. Women explaining that because they come from North Africa, they were given the epidural a bit later because were perceived as being too sensitive to pain. Or women may feel that they are discriminated because of the higher rate of C-section in women from their background. So it's very important to see what we can do in order to better understand the sort of violence that these women are subject to in healthcare settings. And it's true that also in maternities there are a lot of caregivers who, of an immigrant background and of some ethnic minorities. And of course, these interracial and interminority relationship may play a role. So we need to revisit our results on a regular basis. And I may be tempted to say that there's a need to preserve the consistency of the system or even diversify the care on offer. It's true that there's also this network with very good coverage of the French territory with PMIs, which are the centers that are specialized in reproductive health in France, and some doctors who are getting involved. And there are also the role played by associations and NGOs to cater to these precarious populations. Now, it's true that the healthcare system is subject to a lot of, is buffeted by the current situation, but the more we can maintain the fact that our healthcare system is not discriminatory is something which is very important. We need also to rely more heavily on translators or mediators, because in some cases we can see that for women it's maybe very difficult to get an antenatal diagnosis because of a language barrier, because of the jargon that is used by doctors that makes it impossible for the woman to give her informed consent. And likewise, in the delivery room, in some cases, there's a lack of understanding between the different people present. Now, unfortunately, in maternities in France, we see more and more women who come from migrant backgrounds, and they have been faced with situations that were so difficult. And who are so precarious that once they've delivered their babies, they're out there on the street and rough sleeping. So we need to maintain the advocacy to maintain the possibility for these women to get access to housing. There's been a report recently on the 1,000 days, focusing on the social healthcare inequalities, but the report has overlooked these women, and we are several to think that it is very important to make make the housing offer stable for these women, at least for the second and third trimester, because these women are not supported and they have very little help, and no friends, or friends they met only very recently and who can't really support them. So I think we need to do something about this with our initial training, and I have some of my students in the room tonight, and lifelong training. I think the latest generation of caregivers are much more attentive to these women, to these patients, after a period of lesser interest for these issues. I think there's a renewed interest among caregivers to know more and to do more for these patients. Thank you very much, Priscille. Now, you've given us a lot of information, a lot of food for thought. It's also full of nuances and subtleties, and this may call for some clarifications, and I invite you to take the floor and ask questions or make some comments. While waiting for your questions, I'm turning to Caroline to know whether she has a question to ask to Priscille. Yes, indeed. I do have a point of clarification about you. Now, you told us very clearly that for these women who are perceived as African, the high blood pressure is not taken care of properly, or it's a substandard management. How is what sort of arguments do the caregivers put forward? Is it implicit for these women to get this substandard management of high blood pressure? Thank you very much for your question. Now, you see, what is a bit difficult is that there is several sequences in the management with the high blood pressure that is measured by a caregiver. Then there's the urine test strip, and then the women may have to go back to the first station and get another measurement of their high blood pressure, and more particularly if you want to have them get a dynamap, because it may not be readily available in the clinic. It's not, things happen not because caregivers want them to happen. It's just a chain reaction, and some caregivers are arguing that, they didn't want to stress the women or keep them for a longer period to have the blood pressure tested again. Whereas if you listen to French women, they feel that whenever there is a doubt about high blood pressure, they are immediately referred to the dynamap or immediately taken care of. Well, we know, for instance, that obese women are not identified immediately as being at risk. And this woman telling me that they were using a measurement for a special measurement device devised for fat women especially, and otherwise caregivers don't want to keep the women waiting. There's also a lack of proper information of women. They are not told very clearly that whenever they are faced with another episode of high blood pressure, they have to come back immediately. And I feel that also about these urine test strips, it seems to me that the caregivers don't trust these women to perform the test properly, so they ask them to renew the test again and again. And it seems to me that there is some mental representation of these women that is a bit more negative. These women are perceived as not being very capable of doing it properly the first time. And this is what is, you see, interestingly, you see some negative or positive stereotypes about these women. And all this creates a situation where these women are perceived different from us. And likewise, for racism, you discriminate one group against another because you feel they are too different from you. Just wondering, whether there is some bias when it comes to pain management, and also when it comes to postpartum depression. Now, pain management and differential management of pain. There have been a lot of studies, non-published studies, on differential management of pain in women who are perceived as being very painful. For instance, North African women perceived as being more sensitive to pain or expressing more vocally about their pain, whereas African women are perceived as being more resistant or more able to withstand pain. And recently there's been a study in Guyana, and among these women in maternity, it's been possible to show that there's a finer breakdown of these women. Some women, some subgroups of women being identified as being more sensitive to pain and others less sensitive to pain. In the latest study I mentioned, we tried to take a look at when the epidural is given to these women, and we couldn't find any differential management here. We had hypothesized that there was going to be a delayed epidural for these women because a lot of women argue that they were not listened to, that they were painful, but no one took care of that. And not only is there the North African syndrome for North African women, but if you go back in the medical literature, well, Italian women were also perceived as being too vocal about their pain. Likewise for postpartum depression. A lot of caregivers and a majority of caregivers argue that these women are not victims or do not suffer from depression after delivery. Now, of course, some of them are perfectly fine, but statistically, we know that because of their trajectories and because of their precarious living conditions. The stereotype of having these women not subject to baby blues is not something we find in the studies again today.
My name is Maya. I had an emergency shelter for asylum seekers. What can these patients do when they deem that they were underprivileged because of that differential care, and sometimes the diagnosis was made too late, leading to severe pathologies? Thank you for the question. You're totally right. I was quite cautious when I showed you the results, particularly for high blood pressure. You have spontaneous declarations without any past history, and some care can be suboptimal, and that has consequences, of course. It's a bit difficult for me to give you an answer. Regarding obstetrical violence, there are possibilities to appeal to a mediator, an ombudsman in hospitals, but it rarely goes through. Turning to the order of medical doctors, that doesn't go through nearly never. And going to court, that's where justice can be rendered based on very strong medical arguments, but it's very difficult as well. Well, if the medical status of the woman didn't deteriorate, that will not lead to a trial in court. Good evening. My name is Julia. I'm here out of curiosity. A question about differential or suboptimal treatment of African women. My question, those suboptimal or differential treatment, are they applied, are they done by medical staff or caregivers who can be African themselves, knowing the high proportion of African caregivers in French hospitals? And how do you account for that, if it's the case, systemic factors at play? Well, thank you for that interesting question. Very clearly, when I did my dissertation, PhD dissertation, it was very interesting. Among the caregivers I interviewed, some identified themselves with African people, and they felt they were African themselves. They said they were Africans, and they tended to say, we caregivers versus them, the African women. It came out very clearly from their verbatim. However, the caregivers were the most alert on discrimination issues. They would report situations, cases of discrimination that had been totally overseen that others had not seen. But it's a blind spot in French ethnographic study in hospitals. It's what we call inter-minority relations in hospitals. But I think they tend more to claim their common Africanity, Africanness. In delivery wards, you can tell there is a greater closeness between caregivers when they're African or West Indian and their African patients. So it may lead to some hope as to a more equal caregiving relations, but sometimes the minority factor plays in disfavor of some women. They can be told racist. Some female patients might tell a black caregiver, I don't want you to care for my health because you're a foreigner. Or a student, an intern, was identified as a Chinese, and a person would say, I like you because you're a nice immigrant. And he said, I'm not an immigrant. I was born in France. And sometimes the relations can be pretty tough between women, too. A woman might say, hey, the nurse was not very nice to me. And this stirs up such representations, because I'm Arab, she's black. Well, you hear those things, but I didn't work in depth on that aspect. But there is a strong socialization involved in the caregiving process. As we get trained, we're integrated in a group of caregivers, so you tend not to question the protocol. You don't feel legitimate in revising a protocol, deconstructing a protocol that is implemented everywhere, that you think is based on science and evidence. Now students are taught, to read papers with a critical eye, and I get those results. I'm a midwife. I'm not in the hierarchy. I'm not at a level where I can make decisions. So we just wait for the next recommendations by the ministry. But we're often caught up in our hierarchical position or routine. We get bogged in a routine, and that's why people don't often spontaneously decide to be alert on certain aspects of that. There is a question from someone remote, but I'd like to add to the question that was just raised. I'd like to know, to what extent do your studies allow you to bring forth the social criterion? You mentioned that at the beginning, talking about categorization and how women who belong to the middle class, they become West Indian from the French West Indies, and they're not seen as Africa. So there is an intercrossing between racial factors and social class factors, and it can come into play in the inter-minority relations between racialized persons. And, it echoes something for us. Yes, we have to deal with this question of class. Priscilla, thank you. Well, such studies were done as early as in the 1960s and 70s. Lots of studies were done on that. The social peer, as it's called, escapes other types of categorization because people like to recognize their like in the other and stay together. There is literature on that. You see that in maternity wards. But the notion of social value, as Strauss demonstrated, it works very well. He shows that the ideal patient for the nurse is not at all the same patient who would be ideal for the head of department. For the head of department, the ideal patient is a member of parliament who honors him by getting care in his department, or a very well-known famous doctor, and then the nurse saying, oh, this MP, what a bore, he looks down on us. You always have those flows crossing. I've seen very interesting situations, and you can also testify of what you've seen, but for example, okay, the doctor says, okay, I'm going to talk about Mrs. So-and-so, third child, delivery. She was born in Mali. She has this, diabetes, obesity, and she's also a pediatrician. And you see all the interns and caregivers totally destabilized, because at first, they had a totally different picture, and all of a sudden, this African woman is a pediatrician, and it destabilizes them. So it's always at play, those prejudices. When I say we need translators in maternity wards, of course, many women don't need it, but some women do need it, and you have to care for that, for them. Also, people confided in me, colleagues, during the interviews. One example, and we rediscussed it recently with that colleague. She told me it was still the case. Here is her story. She said, I'm a nursing aide at the hospital. She was born in Congo. And she would say, people mistake me for a West Indian black woman. I'm a nursing aide at the hospital, and vis-a-vis many women coming here, I have a very desirable situation. I'm a nursing aide in a hospital. I have a good job. And she said, but I was not supposed to be a nursing aide. I had a problem I had a scholarship to study political science, but then she ran into some hurdles and she decided to learn how to be a nursing aide. But regarding the hospital hierarchy, she would say this black woman from Congo, my direct reports and my boss, they don't know that, they do not think at all I come from the West Indies. They know I'm African. Okay, so we get a question from Dr. Assam Zahi. Do you believe the difference in the quality of care provided by humanitarian organizations in diverse contexts is the result of the implicit bias you mentioned, or is it a more systemic problem having to do with the availability of resources in those various contexts? Wow. Do I dare try and give an answer? I don't know.
La moindre qualité des soins. En tous les cas, ce que j'avais observé, moi j'ai travaillé.
About the lesser quality of care, I went once on a mission in Afghanistan with Médecins du Monde, MDM, and it's a very old experience, so I don't know if I can base myself on that. But the lesser quality of care on the missions abroad. Now here, when we work with immigrant women, Some would say the care I get here is so much better than the care I would have gotten in my country of origin. So it's difficult for them to criticize it because they already think it's very good. And you can find that in the humanitarian context. What quality of care do you offer versus what other care system or a care system, healthcare system degraded by situation? Do we have implicit biases when we go on a mission? Well, certainly. Are we more or less prone to it? Well, it depends on everyone's trajectory or pathway. I don't dare answer to your question, to this question. Good morning. My name is Raphaël. I work at MSF for the Mission France. I have a question about the longer time frame of your research. Did you see these categories evolve? Do some categories disappear for having been deconstructed? Do you see the emergence of new categories? What are the trends about those constructed categories? Many thanks. Indigenous categories by large groups of countries of birth remain stable over time. We still talk a lot of African women. Less so, we don't use the word Maghrebian. They tend to use more the word Muslim because there are visible signs when the women wear the veil, and it leads to a whole discourse and representation. The Roma people are highly discriminated in maternity. Studies have been done on that. And then quantitatively, the others are less numerous, so they don't appear so much in the discourse, but it may be tied to a very local context, a peculiar context. About African women, we wrote a paper with Karakwa on the same observation. This image of African women being very good mothers tends to be eroded today, replaced by the category of women called Nigerian women. It was not present in the discourse of caregivers when I did my dissertation. And the image of the mother and the whore cannot be reconciled in the minds of the caregivers. So they attribute to these women lesser capabilities of motherhood. There were many publications in the media around the prostitution of Nigerian women, many of them coming here to become a prostitute, and that was relayed in the maternity wards. Everybody thought, okay, Nigerian woman, she's a prostitute. Unfortunately, we know that a number of women in high economically precariously situation, they may have sex for money or for food. They're not necessarily a prostitute full time. Are those categories deconstructed? I'm not sure at all. When we might have hoped, I don't know if it's the right word, but we might have thought that with more frequent inter-minority relations in healthcare centers, we would deconstruct those categories quicker. But actually, they are reified and crystallized. Does that lead for all to differential care? We should have to look at that closer, and can be labeled. Can it equate a lesser quality of care? For that, I think we would need an audit process to check all that, to say for sure that the woman got suboptimal care and the incidence of that and the outcome. It doesn't seem so, that those categories are being deconstructed. You might hear something else, but no, I don't think they are.
Laure, je suis psychologue clinicienne et je travaille au CRASH. J'ai une question sur le suicide.
Hello, I'm not a clinician, but I work with the CRASH. I have a question about suicide. It's the first cause of mortality in the year that follows the birth of a child. Do we have data based on the origin of the patients? Is it a risk factor to have been born in sub-Saharan Africa? Precarity, being poor, is really a risk factor for women to suicide in the year following birth.
Triennum 2010-2012, donc l'enquête précédente.
I worked on the period between 2010 and 2012, and I can very well remember the clinical descriptions of these stories about women who committed suicide, but these women were not from particularly migrant background, and they were, however, in highly precarious situations. And for the next period, the next 3 years, I can't really give you an answer, but I don't think so. However, suicide and the deterioration of mental health have been highlighted by the report. And the figure has been, of course, the statistic has been flagged several times in order to try and get more support and teams with psychiatrists for these women. However, if you look at the statistics and the proportion of women born abroad, I don't think this is the case. And these are consecutive 3-year periods that are observed for the reports. My name is Xavier, also work for the French mission. Now, there are 2 things you said at the end of your presentation that resonates very well and very strongly with what we experience in the French mission. The fact that having no translators is something that forbids fairness of care and fairness of management. So I'm just wondering how, as a caregiver and as a sociologist, you're trying to exert some pressure in order to get more translators for these women. There's even some level of institutional violence. The caregivers, because they can't understand their patients, may end up resenting those patients that they can't understand. And these patients are perceived as being complicated and a lot of bother. Now, my second point is about what you said about what you see today and the fact that these women we see today have been subject to more violence than the women we used to see in the past. Do you have any statistics on the heightened violence faced by these women? Is sexual violence taken into account for the management of these women? And of course, you mentioned Nigerian women, and we know that there is a very fine line between rape and prostitution. In other words, is there any acknowledgement of what these African women went through? Or, on the contrary, is there some sort of temptation to turn a blind eye or a deaf ear and not take into account what they experienced? Now, it seems to me that the issue of violence isn't something that is overlooked or on the basis of the data I know of. I can tell you that some of our colleagues, psychologists or psychiatrists, support these women throughout pregnancy and suggest some treatment and therapies for them. and may continue to do so after birth. So it seems to me that these women are listened to, and their violence, the violence they were subjected to, is recognized. Reading some of their dossiers, some of their cases, you are absolutely taken aback, and it's just ghastly. It's just ghastly what these women go through on the migratory route. So I don't have a lot of evidence to give you, but I can tell you, and I want to tell you, that what these women live through on the routes reaches level of violence that is unheard of. And it seems to me that it's not something we used to see in the past. I don't think that it is because, or it is because we didn't really listen to these women. Because when you care for women during their pregnancy, they tell you a lot of things. They tell you about their stories. So I don't think we were turning a deaf ear to that. Now, of course, things may happen in families, and obviously, and there are some terrible situations and violence in families as well. But it's true that these women, because of the policy pursues vis-à-vis migrants in our country, makes it very difficult for these women to find their place. And this is why they may end up on the street a few days after delivery. Can we support you in your advocacy about translators and the need for translators and mediators? Well, obviously, with pleasure. In our institute, Institut Convergence Migration, we would be glad to do so. However, I want to remain very humble. I can't change the whole picture whenever I visit a ward in a maternity, of course, but we can participate in collective action. I'm seizing the opportunity of having the microphone to make a very short comment and asking a question. Thank you very much for everything you told us. That resonates very strongly with what we go through on our side with the increased burden of work in hospitals in France. And it's true that it's also something we experience in our settings where the ratio between patients and caregiver is even worse than in French hospitals. And it's probably one of the factors that may explain why we can't really offer personalized management. And there's also something I'm wondering about these categories. Categories are nothing new. New categories are created. However, there are some areas where you see some progress, like access to counseling, for instance, and psychiatric support. So what are the levers that enable these positive changes? Just to take the example of counseling and psychiatric care. No, thank you very much for a slightly rosier note to our debate. What are the levers? Well, because the counseling offered to these women was in the aftermath of the in the wake of the 1,000 days report. What can we do? Well, obviously, having more time. And recently, I conducted a study across PMIs, the reproductive health centers in France, and these colleagues who work in those centers were telling me that they had decided to take more time to listen to the women, listen to their stories, and interestingly, women didn't know that these were specific consultations. So this may be a very positive differential care, but we don't advertise it as such because we are afraid of being perceived as discriminatory. So it's always very tempting to highlight the improvements we introduce in midwifery. We have 85% of research that pertains to the 15% or so of women with conditions during their pregnancy. So how can we contemplate doing more for differential care? Personally, I'm a strong believer in training, a lifelong training with modules on these particular issues. We have introduced a more comprehensive training for midwives. We've also started to give some training to medical students, and some of them are now more aware of what they can do in order to improve the situation. So maybe it's being utopian to say so, but of course training can help. However, it should be, or if we want to see tangible improvements, we need to put this on the political agenda. It's in order to remedy the inequalities affecting some of these children. They don't have the best of start in life. If we could show that with a strong political will to make the housing for these women more sustainable, give access to translators or mediators, well, how it could improve the lives of these women and their children. Do you think that it's how come that counseling was offered to these African women who are perceived as not very keen on getting counseling? Well, I think it all started in some 15 or 20 years ago in the general population, and we could deconstruct the approach to African women and counseling on the basis of public health data, and we could show that these women were more at risk. Now, in line with Marion's question, I was just wondering whether you could give us more detail on the research you carried out for your thesis about the statistics on C-sections. You were telling us that some care is medically justified, but other other type of management isn't. And that it was shown that C-section was something that was resorted to too frequently, and that you could convince caregivers that it was the case, and that the rate of C-section decreased. Though the C-section was perceived as more common among these women because dependent on biological factors. So maybe it's also a way to make sure that caregivers become more aware of the bias. Now, thanks to my thesis, I was able to identify something quite specific to French obstetrics, quite unheard of, I think. Prior to 1980s, there used to be a maternity in Hospital Saint-Antoine in Paris. It's no longer open now, but the head of the maternity and the team were summoned by the Senegalese authorities, who complained that the women from Senegal were getting more C-sections than others, and they were told that C-sections were not as readily available in Senegal, and that these women could be more at risk, therefore, when returning to their home country. And Professor Mignet and Miguels revisited their statistics and their patients' cases, and they could show that 20% of African women from sub-Saharan Africa had a C-section versus 10% for French women. And so they reviewed their data, their statistics, and they came to realize that indeed it was true. And because I can still remember from my midwifery school that we were told that African women had narrower pelvis, and maybe because at the time the prevalence of polio was still quite high in Africa, and also because these women were having babies at a younger age. And so there was this sort of fantasy that the pelvis of African women was narrower, and they started to apply a new protocol in order to avoid performing a C-section too early, measuring the pelvis, also giving some time to the baby to get a bit lower, and there is a third indication to take into account in order to avoid C-sections, and they could show that within 1 year they were back to 10%, down to 10%, on par with the general population of women. And the paper was published but not digitalized, so it's no longer possible to read it. But other teams then started to apply the same protocol and could reduce the statistics about C-section without any morbidity for neither baby or mother. Of course, these were limited series, and I'd be very glad to perform the same study again, but we can no longer reproduce the same sort of study because there would be too many biases. And therefore, my colleagues are not willing to embark on such a study. you can see in the general population study that there is a very high rate of C-section among these women, but because we don't know, we don't have any information about the root cause for the C-section, we don't know, in fact. So, and this is probably why the question has never been thoroughly revisited, and probably why you can see that there's a higher rate of C-section among these women in cohort populations. A colleague recently worked on the cohorts of hospitals in the northern part of Paris, and they could show that these women had undergone C-sections, and they had a lot. There was a lot of scar tissue in the uterus, but it's the only specific feature. Otherwise, you can see that there is a higher rate of C-section among women.
Mais en tout cas, je trouve que l'exemple est vraiment intéressant, puis finalement rejoint.
It's not easy to redo that study, but it's an interesting example, and it echoes what we said earlier. When there is a political will, political pressure and determination, it makes the lines move. A question from Jean Calibucci. What are the most frequent indications for C-section in African women? Is there a difference between a well-experimented gynecologist and a less experimented gynecologist? Thank you for this question. It's not really easy to answer. When it comes to the experience of the practitioner, the surgeon, we have some assumptions, but it's difficult to demonstrate. In all the teams, usually you have senior and junior surgeons. But there was a very nice piece of work done by a team in Besançon hospital. They work a lot on their C-sections and indications, and experience plays a role when you have a delivery, a reverted delivery. So the experience of the surgeon plays a role also for twins. And, you know, it's not necessarily a young obstetrician who would advise a C-section. Some people, you know, some practitioners would try longer for natural delivery, vaginal delivery. Now, as to the indications for C-sections, none is really specific of sub-Saharan women in France. In older days, they had systematic C-section to avoid the transmission of HIV from mother to child. It was done systematically, but now it's no longer relevant. It's no longer pertinent to do that. And then you have the conventional indications, the heartbeat of the fetus, of the baby suffering or degradation of a maternal pathology, or if because now they induce labor in women more often, and that might be connected with the resort to a C-section. That's the best I can tell you in this question. Thank you. Well, I don't really have concluding words. I just want to thank you very, very much, Priscille, for this presentation and all the exchanges. It was really interesting. I'd like to thank the interpreters, Eve and Caroline, also Joël Ramello, the sound technician, and then this conference will soon be available as a video. You're used to that. But you will also find it as a podcast. That's new. So let's do some internal promotion. The Crash is launched yesterday, its own podcast channel called Critical Zone, Zone Critique, and you have 3 different series of formats of podcasts, and you have the audio. recording of the crash conferences, so you can listen to it again without having to use the video. Many thanks.